Dr. Zariba and everybody there on this Saturday, December 5th. Thanks for having me, Wojciech. It's great to be with you all. And I was looking at some of the participants' name as you were making the introductions, and I recognize many of your names. I've had the privilege to be in some of your long QT specialists for some of you, and for all of you. Thanks for choosing to spend your afternoon or late morning with us. And I'm really privileged, Wojciech and Ilan and your team, to be asked to kick this off and be your keynote. And so for the next 20 minutes, I'm going to give us the state of genetic testing for long QT syndrome as we move into 2021. These are my conflicts of interest to disclose. Specifically, I am a consultant for one of the genetic test companies, Invitae, but I don't think it's going to adversely affect our ability for me to help you all assess what is the state of genetic testing for long QT, what is its yield, what's its clinical impact, and then what's the problem with the genetic test in terms of the so-called VUS issue. We will soon celebrate the 20th anniversary of the completion of the Human Genome Project, and 18 years ago, it was declared one of the greatest feats of exploration in history, an inward voyage of discovery. And some might add a subsequent journey in chaos and confusion, and I'll come back to that. That breakthrough led its way to genetic testing being ushered into clinical practice for all types of diseases, and our field of the genetic heart disease was no exception, where we have genetic testing clinically available for long QT syndrome since about 2004. And we've had guidance for the first time 9 years ago for how should we, clinicians, heart rhythm specialists, non-specialists, use genetic testing. And so in my 18 and a half minutes and counting on my counter, I want to leave you with the ability to have good answers to these three questions. What is the genetic test impact across the triad of medicine? What is that genetic test for long QT syndrome's yield? And what's the problem with the test? What is its Achilles heel, its noise? When we think of long QT syndrome, I'll give you a reminder of the timeline of this journey we've been on for the last now 63 years since the first clinical description that ultimately gave way 25 years ago to the birth of our entire discipline of the cardiac channelopathies, when Mark Keating revealed to us the root cause being defective ion channels in the heart, where we now know that 2/3 to 70% of all long QT syndrome are due to loss of function mutations in one of two voltage-gated potassium channels, like this voltage-gated potassium channel shown here. That discovery then ushered in the decade of research-based genetic testing, which we entered in about 1998. That ultimately gave way to the first clinical genetic test for long QT syndrome in 2004. Some may remember the name Familion, which Mayo Clinic participated in. Guidelines emerged where third-party insurances companies started to view these tests as bona fide clinical tests and not research tests. And as mentioned, we had the guidelines in 2011. In 2020, this is the compendium of long QT causative genes. There are now 17 and counting. You can see where you are and say, oh, I'm LQT9 or I'm LQT17. Now, most of you as families are going to be either LQT type 1, type 2, or type 3. These are the three canonical, the three major long QT susceptibility genes for which we know a lot about, and some of the subsequent speakers will be discussing how we treat long QT syndrome as we enter the newest year, and what triggers the different long QT types, sports, activity, adrenaline for type 1, noises, auditory cue for type 2, the postpartum period for type 2, and how we have excellent genotype dependent responsivity to our therapies. Beta blockers work great for LQT1 as an example. we have been doing genotype-based risk stratification, genotype-guided treatment, and we have now been doing intragenic risk stratification. In other words, not all LQT2 is the same. It's kind of like, what kind of LQT2 are you? Where is your mutation? What is the functional sequelae of your LQT2 caused mutation? And the late, great Arthur Moss, who we all remember fondly, started this off almost 2 decades ago, where we demonstrated that those with poor localizing mutations in the LQT2 associated potassium channel, they behave more poorly as a general rule. And so these are some of the reasons why, as a long QT specialist, as a clinician, I want to know your mutation. I want to know what kind of long QT syndrome do you have? Are you type 1, 2, something else? And because when I think about the genetic test impact across the triad of diagnostic, prognostic, and therapeutic, long QT syndrome still leads the way, in that the genetic test for long QT syndrome is the best genetic test we have in genetic heart disease. And because of that impact across the triad, the guidelines for 10 years now have been crystal clear. A class 1 recommendation, it is recommended to do genetic testing on any patient that we as a clinician are going to call you, the patient, long QT syndrome. That was reiterated with the most recent guidelines from all of the major cardiac societies in 2017, when we said it is a class 1 recommendation to do genetic testing if we're going to diagnose you with long QT syndrome, and class 1 that we must do variant specific genetic testing in the appropriate relatives. In other words, genetic testing has not been research for long QT syndrome for a long time. It is the standard of care clinical practice. With the impact across the triad being able to be answered, let's look at the second question. What's the genetics test yield? I think you have long QT syndrome. I know you have long QT syndrome. What's the likelihood that I'm going to get a positive genetic test result back? That's the yield. And when we think of the yield of genetic testing, again, it is the best among all of the cardiac channelopathies. As a comparison, the yield for short QT syndrome, not good. For Brugada syndrome, not much better. For CPVT, a different genetic heart rhythm condition, really quite good, because that is 60% for one gene alone. But then for long QT syndrome, it is really good. 80% yield, and that's really with just the big 3 major long QT genes. This is more for your physicians than for you yourselves, but I like our clinicians, our diagnosticians, to be thinking about what's your batting average. I want Dr. Vineker to know what is his batting average among all of the patients for which he orders the long QT genetic test. And I hope he's not over here on the right, because there's a colleague on the right who loves to brag that he's been told by one of the genetic test companies that he has the highest batting average in the industry, that of all of the tests he's ordered, his yield is 80%. And I just shake my head at him, and it's a him, and I say, don't brag. That's not good use of the test. You are underutilizing the test, because the only way you can have a yield this great is if the only cases you submit are perfect cases of long QT syndrome, and they don't always come with a whopping obvious phenotype. On the other hand, I'm glad that nobody on Dr. Zariba and Dr. Goldenberg's panel is on the left, but there's a colleague, I don't know if we can call him friend, who is in a bit of a slump. He's ordered the genetic test over and over and over again, and he's still waiting for that first magical moment of it came back positive. So this person has a problem. He is either an early adopter to universal genetic testing, or he does, and it's a he, does not have the foggiest clue of what constitutes the phenotype of long QT syndrome for which genetic testing should be done. He's overutilizing. What should your yield be for the physicians? Somewhere in this range. Don't have a dull sword like this person over here. And I bet some of you might be curious of who he is, and I'm going to reveal it today, December 5, 2020. I'm just kidding. It's Zoom world, so I wouldn't do that. But we have a long way to go in our field to help make individuals better phenotypers, better diagnosticians, because the phenotype is the most important to guide the likelihood of the genetic test coming back positive, and also the appropriate interpretation of the genetic test, which I'll come to shortly. I teach the physicians and the healthcare providers out there that if you are not certain of the phenotype, don't go fishing for a genotype. There's another important corollary with this yield of 80%, which is really important, and that's this. If that genetic test comes back negative, as in nothing's found, negative, remember that although a negative genetic test cannot rule out the diagnosis of long QT syndrome by itself, but if that genetic test is negative, the phenotype better be really strong. In other words, the beauty of this genetic test is it's unemotional. And it is a good arbiter, not a great, but a good, where by itself, it rules out 80% of all congenital long QT syndrome when it comes back negative. So if it comes back negative, time out, physicians out there, you better be redoing and reassessing the clinical evidence and making sure, are you still going to call that patient long QT syndrome? Is that still the correct diagnosis? It might be. 20% of patients who truly have long QT syndrome can be genetically elusive, but a negative genetic test demands a clinical relook, redo to see, are we still going to call that person genetic testing? In addition, with the implications of the genetic test, this is the reason why we said we have got to do variant-specific genetic testing in the appropriate relatives, no matter what the ECG shows. This ECG is as normal as it comes, and yet this person owns the family's LQT1 mutation. In other words, a normal ECG in a family with long QT syndrome cannot rule out the diagnosis. Only a negative genetic test can. So families out there, if the physician has said, we don't need to do the genetic test in you, your ECG is normal, not good enough. Good start, not good enough. It must be accompanied by a negative genetic test when that family is part of one that has a known LQT causative variant. What's the impact across the triad? Really good. What's the test yield? Really high. And the last 7 minutes and counting, what's the test's problem? What is the Achilles heel of genetic testing for long QT syndrome, specifically for all monogenetic diseases in general? And that is this. When the test comes back with something, the X that marks the spot, how sure are we that is truly the disease causative mutation, or now politically correct, the disease causative pathogenic variant? Don't want to call anybody a mutant out there, so variant. And it's not so easy. These things can be common or rare and not matter. They can be common or rare and alter biology, or they can be rare, and they better be rare if it's going to be a long QT causative variant, and indeed be the cause. We need to be more responsible as diagnosticians, as users of genetic tests, and be more careful with genetic test interpretation and be more engineering minded so that we think of what is the noise in the system, what is the signal to noise ratio. And let me expose this and expand on the background noise issue. Some act out there as if this is a new phenomenon. Oh, we didn't know that there was noise in the system. And I think it's important to remember this paper and this year, the same year of Jubilee that the Genome Project was declared one of the greatest feats in history. We said, be careful. There is noise in the system. The following year, we said there's noise in not just the potassium channel genes, but in the sodium channel genes. And how did we come about to expose the noise problem? Well, we did the reverse experiment. Here are the putative LQT causative variants in the LQT1 channel, 2 channel, and the LQT3 associated sodium channel in patients who had a phenotype for long QT syndrome. But then here, check this out. We did what was viewed as radical back then. We did sequencing of not diseased people, but 1,000 blood donors. And the skeptics said, why on earth are you doing that? That's a waste of time and money. There will not be rare genetic variation in these disease causative genes that would not be allowed. And we raised our hand like Tom Hanks in the movie Big. I don't get it. And we didn't get it as the why. We said, who said that that would be the case? And indeed, that was not the case. There is rare, uncommon genetic variation. 4% of Caucasians have something rare in the irrefutable top 3 LQTS genes. And what you can see here when we said back then, be really, really careful, is that the noise is not randomly distributed across the genes, across the gene encoded protein. And while it would be really difficult to interpret the pathogenic significance of a variant down here, a lot easier if the variant is up here. And we'll show that in just a second. In other words, we emphasized and have been emphasizing that genetic tests are not binary, yes, no, just give me the answer tests, but they're fundamentally probabilistic in nature. And that creates a problem. And that is the decoders of the genetic tests need to be us, the phenotypers, and not be reliant on the genetic test report by itself. Interpreting a genetic test is not called literacy, where I read it. It's called decoding, where I interpret it and I decide whether I agree with the genetic test company's report, just like I decide whether I agree with whether the ECG machine measured the QT interval correctly. This brings us to the maybe test result in our 3 minutes and counting, and that is the VUS. They got called possible deleterious variant in the past. Nah, I didn't like that expression. They're now called the variant of uncertain significance, or I have a VUS, and that is technically an ACMG class 3 variant. What I refer to all of these as is genetic purgatory. This place of uncertainty is a real place, and it's really scary as to how the physician community is prosecuting these variants, how patients are interpreting these variants, how doctors are acting on these variants. And there's a couple of key principles to get out of purgatory or navigate our way through it. And that is, first, variants of uncertain significance are not all created equal. It's not just the one and the same. This is where the power of the phenotype can help you. And I'll give you 2 examples. You own a CAV3 VUS. Real mutations give you LQT9, but if you are a new variant in that gene, that variant is demoted. Like all variants in a minor gene, those variant VUSs are stuck deep in genetic purgatory with no easy way out. But then what if you have this variant of uncertain significance right up there, and it has this amino acid? And I hope you're watching, those of you out there who sent this to Dr. Zariba, because this is your question. And your genetic test company and your physician team has called this a VUS, serine 624 cysteine. And I say, well, wait a second, that VUS, let's say I didn't know what kind of long QT you were. I just knew you had long QT syndrome. That's not a VUS. That's a long QT2 causative mutation with 25 to 1 odds. On the other hand, let's say even before I ordered the genetic test on you, owner of S624C VUS, and I predicted that you were going to be LQT2 because of your story, because of your ECG, that VUS is not a VUS. That is an LQT2 causative variant with 100 to 1 odds. The point, the power of the phenotype to help us adjudicate and reposition a VUS that the company told us it was. It starts there, but then I can promote it like that to a likely pathogenic variant or demote it. Well, my counter has come down to the end as I leave you these take-home points then. First, long QT syndrome is our most common of the heritable channelopathies. We're at 17 long QT susceptibility genes. That yields a really good yield. It has implications. If the test is negative, we better look at the phenotype really closely. Genetic testing, second, is the standard of care for long QT syndrome. If you're being taken care of by any physician who says, I don't need the genetic test, they're practicing ancient medicine, not contemporary medicine. But these genetic tests are probabilistic tests. X does not always mark the spot. Believe in genetic purgatory. By believing in it, you can help navigate your way through it so that we can all be a wise user and a wiser interpreter of genetic test results for our patients and the families that all of us have the deep, deep privilege of caring for. So thanks for having me as your keynote. I just acknowledge these entities that have supported our program, especially the philanthropic support of Wendy's family to help us heal the sick and advance the science. Tell your physicians to join me in about 10 months for our 5th annual Genetics of Heart and Vascular Disease course. You'll be glad that they went to this course. They will be glad that they did. And I'd love to entertain any of your questions that you have now or anytime throughout the next 3 hours that we're together today. Thanks, everyone.
Thank you, Mike, very much. It was very informative and very stimulating presentation. Obviously, we welcome questions from our audience. And one of the first questions which came was related to how early you could start doing genetic testing in newborns.
Yeah, so from my vantage point, we test them immediately. I don't really see a need of fetal genetic testing from amniocentesis. I suppose if there was a different obstetrical indication for that, you could. We've done that only a couple of times for, I guess, family anticipation and planning or trying to resolve fetal bradycardia when the mother was on beta blocker therapy. Very few times, I think 2. But we do genetic testing of the baby. We collect the sample the day of birth, on their birthday. And we then are positioned to know within 10 to 14 days whether we will be navigating a journey with an LQT positive child. If they come from an LQT positive parent, it's a 50-50 chance that each baby they create will be positive. And so my view is, why not know that immediately so we know how to navigate and chart a course that will be one where that baby will live and thrive as a baby, as a toddler, as a teenager, and beyond. So we test right away.
Thank you, Mike. So you can see maybe in chat room, there is a question about a patient with 2 children that have been tested negative for known genes. What can we do to promote further exploration for our and other unknown genes that cause long QT? You partially touch on it, but feel free to
I think the first thing, if your current genetic test has been negative, and the reason I emphasize current is, I think Wojciech and I have recognized that any family whose genetic test was done back in the research decade of genetic testing, and it was negative back then, even if it was in my lab, that's not a good enough genetic test. Our tools were prehistoric in the late 1990s, early 2000s. So I would not call that a negative genetic test. I'd call that a negative research test. So if you were negative based upon a test from 2002, repeat the genetic test with one of the contemporary clinically available genetic tests. If that genetic test is still negative, then this next question should be, do I really have long QT syndrome? Because that genetic test just ruled out 80% of all long QT. If the answer is yes, I really do have long QT syndrome, but my genetic test is negative, then you are potentially one that would enable our team, Wojciech's team, to do gene discovery and identify your unique gene responsible for your long QT syndrome. So if you really have it, you should be connecting to the research world, my team, their team, to get your blood sample collected, to get your pedigree expanded, and then do current whole genome sequencing of your entire genetic code and let the research world sleuth to try to identify your family or your personal reason for your long QT syndrome.
So you pointed out about this 20% or 30% of people for whom we don't know. I want to re-emphasize what you said, that phenotype, meaning clinical presentation, is extremely important. So if one has some clear QT prolongation or symptoms without even known gene, this is what Dr. Ackerman mentioned. We are very much interested to explore this further because this might lead us to better understanding of the mechanism. So following to your comments, there is a question from audience about whether test was done in 90s. Should people do regular testing right now, repeated? What do you think, Mike?
Absolutely. I think there's two reasons. If you were in that research era and something was found and it looks good, as in good enough, and there's no surprises, then you can stop and go with that and have all appropriate relatives confirmed with the present day test. But one of the things that was done back in that era is most of us did what was called a find and stop strategy. If we found it, we stopped. And so we would not then necessarily have found a second hit. And as you know, Wojciech, about 5% of all long QT probands have a second mutation for which back in that research era, we may not have found that second hit based upon the find and stop strategy that was utilized. But more importantly than that scenario is if you were called negative because of a 1999, 2001 research test, get a 2020 clinical genetic test done before viewing yourself as negative. The miss rate based upon our research platform that we used in the late 1990s, 2000 was at least 10%, meaning there was truly a mutation there to be found, but our tools and techniques were not good enough to find it 10% of the time. So get a current negative test, a current genetic test before you call yourselves genetically elusive or gene test negative long QT syndrome.
I would invite maybe Dr. Ilan Goldenberg to say a few words about people who are genetically positive, but phenotypically clinically negative. He put together a very nice analysis a couple of years ago on that. And could you comment on that? Because it's another side of the coin that you have genetic positive, but you don't have much QT prolongation or even much symptoms. Ilan, could you comment briefly on that, please?
Yes, about 1/4 of patients who are being tested positive for long QT syndrome have a phenotype negative, meaning that the QTC is considered to be in the normal range. Most of them are identified as being tested for the same family mutation, so they're identified to have long QT syndrome, but not based on a QTC prolongation. And in this subset, we looked at the risk of life-threatening events, so body cardiac arrest and sudden death, and we had identified, like Mike said, within the mutation, there are specific high-risk areas, mutation location, like we identified the pore loop, the transmembrane, or the C loops. In those areas, there's still a substantial risk of sudden cardiac death despite the fact that QTC is normal. And this further stresses the importance of genetic testing not only to identify the risk of the subject, but also to improve risk stratification to identify those who may need therapy even long-term.
And that's so important, Ilan, and that's exactly why a normal ECG, when you're part of a known family, isn't good enough. You have to have a negative genetic test, because although that individual's risk is super low, like you showed, it's not zero. And the tragedies that have happened in those individuals have almost always been physician-mediated tragedies, meaning some doctor somewhere put you on a drug that was on the QT hit list, and that took your dormant, low-risk, normal ECG long QT and exploded it. So you are low risk, but I want to know how low your risk is so that I can make sure that nobody puts you on potentially dangerous medications without our review and our permission.
Excellent comment. Thank you, Mike. And I believe last question I see on the screen is how is current genetic test order? And probably my brief answer is you need to contact your physician who will order this test for you. So I believe that it's perfect timing. We are moving to our next talk by Dr. Ilan Goldenberg, who will be speaking on updates on drug therapy in long QT syndrome. Thank you.